Thank you, Maria. And here's one more follow-up question on variants from our viewer on Twitter. Is there a relationship between active case level and new mutation creation?
Yes. The more virus you have, the more chances the virus has to adapt. The more people that are infected, the more times the different variants of the virus, variations of the virus, have an opportunity. So it's opportunistic. It's random in that it's not been driven by anything particularly that we are doing right now. But it's been driven more by the background level of cases. If you imagine, we're in a scramble to control the virus, but the viruses are in a scramble with each other for who gets to survive. And like in all evolutionary processes, and we know that with evolution, that small random changes in any organism can confer on that organism an advantage or a disadvantage. Sometimes, very often, a genetic change confers disadvantage and those lineages die out. Just now and again, a random change in the genetic sequence confers an advantage. And that's how evolution happens. That's how we got here. That's why we're who we are. The process with us has taken millions and millions of years. Viruses are the fastest organisms on the planet to make that adaptation because they exist in their trillions and trillions, and they're infecting millions and millions of human beings. Therefore, they get to buy a whole lot of lottery tickets in terms of their ultimate objective. I won't anthropomorphize them. The virus has no objective. It's just reacting to the realities around it. So therefore, more strains and more variants will emerge. It's a natural process, as Maria has said. But it's all the more accelerated when we have so much virus and so many people infected. So if we can get the numbers of people infected down to a much lower level, then that force that is driving that selection process will decrease. But it won't disappear entirely. These viruses will continue to evolve and continue. That's why, as Maria said, we need constant monitoring of the variants of interest, the ones that pop up, but then to be able to sift out from all of those variants that emerge, we need to be able to sift out the ones that are of concern. So if new variants emerge and they just happen to have a slight difference that doesn't confer any specific advantage to the virus, then they're as likely to die out as not remain. But the variants of concern in general tend to replace the other variants because they effectively are more successful in their process of passing from person to person. And once they're more successful in that, they will eventually replace the original wild-type viruses.
Thank you, Mike.
Can I supplement that?
Sorry.
I just want to supplement that WHO isn't working alone in this space. So we are working with countries all over the world, ministries of health all over the world, agencies, all of the CDCs around the world, the US CDC, the Africa CDC, European Centers for Disease Control and Prevention, like all of this, the CDCs. And everyone out there right now, we have a peaked interest in genomic sequencing at the moment. And we need to use this opportunity to catalyze improving genomic sequencing worldwide, because it will not only benefit SARS-CoV-2, it will benefit all the work that we do on tracking viruses and pathogens around the world. And we have an opportunity right now to focus on enhancing existing systems. It's not about reinventing the wheel. We have incredible systems that are in place through our GISRA system, which is our flu network, through HIV labs, TB labs, polio labs. I just got off a call, coming to this meeting where we are actually working with many partners around the world to say, okay, how are we doing? How are you doing on increasing your sequencing capacity in the area where you work, in the region where you work? And where are the gaps? So we are looking to map the sequencing capacities. And if we cannot find that capacity in a country, how do we support that regionally? We do not want to reinvent the wheel. And I will say that again, because we want to support the systems that are in place, to reinforce those systems in place and build something that is long-term. So we use SARS-CoV-2 and the variants of concern as a real catalyst to kind of drive this forward. We have a lot of partners and funders that have reached out to us who want to support this, and we are so grateful. And we are working to consolidate all of this interest and kind of drive this forward and coordinate that response. We also need to tap into other untapped resources in countries where we have private labs, academic labs, veterinary labs, where you have that capacity local. But it goes beyond the sequence itself. We need platforms that exist that can house these sequences. Platforms like GISAID and others around the world, so that they're shared and so that analysis can be done with them. Sequencing for sequencing's sake is not helpful. What we need is the sequences to be shared with supporting data like clinical data or epi data, so that we could do what we call phylogenetic analysis and genetic epidemiology to understand virus evolution and transmission and what this actually means going forward. But we have a real opportunity here to build that. And this is done through collaboration. I have to say, as Mike was saying, this has been really hard for all of us in 14 months. And we all have our, really down days and troubled days, but the global collaboration around this, the interest in countries wanting to work together to share expertise, to train, to build capacity, to share results, before they're published in peer-reviewed journals for action so that we can collectively drive transmission down is inspiring. And we are so grateful for everyone that continues to work with us, to really end this pandemic. So I just wanted to take a moment to thank everyone that's working with us on this, because WHO, we don't do anything alone. We've got amazing staff around the world, but we have amazing partners around the world. At WHO, our teams, Mike's teams, in our health emergency program and his health emergency program, we work with thousands of scientists around the world, thousands, every single day. And that, we probably don't thank enough. So we're grateful for that continued effort to work with us for a common collective goal. Thanks, Alex.
Thank you, Maria. Here is the next question coming from Ruth Ramirez podcast on Facebook. From the onset of COVID, it was determined that the virus would live in the environment for a period of time on various surfaces. Because of new variants, do we know if they are able to sustain their infection rates higher on various surfaces?
That's an excellent question. I don't have a complete answer to that because some of these studies are underway. So anytime we have a new virus variant, as I mentioned, there's a number of studies that need to be conducted, one of which is looking at virus survival. There's a lot of experimental studies that have been done in the lab to look at different conditions, different humidities, different temperatures, even lights on, lights off, of how long at different surfaces, paper versus steel versus cardboard versus wood. And those are experimental studies. I have not seen any studies that suggest that virus persistence is different with these virus variants versus the common type SARS-CoV-2 viruses. Should that, we see anything different, we will certainly, make people aware of that. But I have not seen any indication that there's a difference in the way these virus variants transmit in terms of the modes of transmission. And we haven't seen any indication, and we've specifically asked in countries where these variants are dominant, where they're circulating widely, are any of the interventions that are in place not working? Do you see any alteration, any increase in cases where you wouldn't expect where your interventions are in place? And we have not seen any changes in the modes of transmission. We have not seen any change in the way it spreads. And that's important because with any change, everyone wonders, what does this actually mean? Well, what it means so far from what we have seen is that our interventions work. Our infection prevention and control measures in health facilities as well as outside of health facilities work. The wearing of masks work. The hand hygiene works. The avoiding crowds work. Opening the windows work. All of this is really important. And so I think it's important to reiterate that.
Thank you, Maria. Here is the question from Stephen Michael Chidiaber. I apologize if I didn't pronounce that well. When you have COVID, how will you know that you have it? So, Mike, maybe you can remind our viewers of different symptoms they can recognize, and they should maybe go for tests and see a health professional.
Yeah, I think it's quite tough actually, because the basic symptoms of COVID are essentially like a bad cold or a bad flu in some cases. So generally people can feel generally unwell, malaise, they just don't feel right, and can get fever or chills that go with that not feeling well. They may or may not develop respiratory symptoms. They may develop a runny nose, they may develop a cough, they may not. They may lose the sense of smell, and that's been a common feature in the disease, but not specific to COVID-19. There are different phases. So generally the first phase of the disease is that fever phase where you just feel terrible. You may or may not have respiratory symptoms, and very often associated with fever. For the most part, people, and especially younger people without underlying vulnerabilities, will tend to get through that phase of the disease and recover. But a small proportion of them continue to have, even though they clear the virus, they continue to have longer term symptoms, and we've seen increasing evidence of long COVID, even in people with mild or moderate disease. For a proportion of people, particularly those people with underlying vulnerabilities, and particularly for older people who experience COVID, after that virus is cleared, very often people, and in some cases people can even feel a little better. They get rid of the fever and they think, oh, okay, the fever is gone. And then there's a second phase of the disease. It's usually after about day 8 to 10, after the onset of their symptoms, where they can develop this more serious disease, which is really mediated by inflammation in their system, either in their cardiovascular system and particularly in their respiratory system, in their lungs, where there's a kind of an overreaction from the immune system. Your own immune response is fighting the virus, and it sort of overshoots the runway, and you end up with this inflammatory disease in terms of your lungs become more inflamed, and in fact prevents oxygen passing between the air sacs and the blood. And that's the stage where very often people use corticosteroids and drugs like dexamethasone to try and reduce the inflammation. So there are kind of two phases to the disease, and it's not always the case. Nothing is absolute, but that's how it happens. So if you, and right now, given the level of prevention that's gone underway for all respiratory diseases, the incidence of influenza is very, very low. So if you're experiencing mild to moderate symptoms, particularly fever and respiratory disease, I mean, kids and others get the sniffles all the time, but it's not usual for adults to feel, the impact of respiratory disease, then, you are a suspect case for COVID-19, and you should be tested. And that's, I think, the most important thing, is that you take action, get tested, isolate yourself from others, make sure your contacts are identified. And you don't need contact tracers always to identify contacts. If I get sick and I have COVID, I should be telling everyone that I've been in touch with that I have COVID, so that they can then take the necessary action to protect themselves and others around them. But testing is a very important part of this, because we're not always sure. And as I say, there are other conditions out there and other causes of respiratory disease, and particularly with people with underlying conditions. People can have other pneumonias that are perfectly treatable with antibiotics, for example. So it's very important that especially people with underlying conditions are properly examined by a physician, by a nurse, so that they can be properly assessed and put into the right clinical pathway. But it is tough at the beginning to be able to distinguish between COVID-19 and other respiratory diseases. Best to be safe than sorry. Best to get tested if you can, and to look out for yourself and others in that process.
Thank you very much, Mike. Maria, do you have anything to add to this question?
Well, I'm just thinking on a practical standpoint. I have a husband and 2 kids, and I have a little one who's 2 years old who's in creche. And little kids get sick a lot. And you just think of, they come home and there's a lot of germs that circulate around. And I'm particularly thinking about this because in many countries right now, schools are starting to open again. And this is absolutely wonderful. In countries where transmission is being brought under control, kids are going back to school, and there are many safe ways that kids can go back to school and making that environment as safe as possible. And